we have switched the order around just slightly. Dr. van der Spey should be joining us shortly. But in the meantime, Professor Ramakers is going to speak to us first. Professor Eugene Ramakers is a professor in pediatric rehabilitation at the University of Hasselt. I hope I have that pronunciation okay, which is in Belgium. He is in the Department of Rehabilitation Science, and his CV is very extensive. And I certainly won't try and go through all of it.
No.
But certainly, I can tell you from 2000 to 2010, he was the editor-in-chief of the Dutch Journal of Pediatric Physical Therapy. And from 2010, among many other committees, he's been a member of the Dutch Power Platform for Children with CP and a member of the International Consensus Group on Constraint-Induced Movement Therapy. He has many research projects, of which several are international collaborative projects, and over 60 publications to date. And as we discussed, he keeps very busy, but we don't say he works too hard because that would be the wrong connotation. So I would very much like to invite Prof to address us. We'll keep admitting people coming in, but let's, I think, get going. If you want to share your screen.
Yes, if it is all right, you just see.
Sure, that's perfect.
Full screen. Okay. Nina, thank you for the invitation and for the possibility to have a presentation, a short one, to share to you the related to the unilateral spastic CP kits and related to the upper limb treatment modalities. And this is a huge discussion in research already about 2 decades. And I will guide you through the most relevant ones and show you why they are successful or not. And I hope to share you some examples. Spastic unilateral CP. The first question is, okay, but why would it be important in spastic CP? And if you, and now I need to use my pointer, that's more easy to see. If you look in children with cerebral palsy, many elements are labeled as very important in this group. First of all, the spasticity. That's one of the types within CP. The next one, important one, is selectivity of movement, so precision and coordination of the movement. And relative new one since the last decade is muscle weakness, both in upper limb and lower limb. The range of motion problems called contractures, and the inactivity problem. And if you place these within the ICF model, I expect that's very well known for you all, then they are all related to the body function and structures. But these constraints, they hamper the participation both in activities, sports, leisure time, school activities, but also at the level of participation, so official sports, official group activities. But while performing these activities, something is happening. Because being active, you need to have muscle tone. And if you have already a lot of muscle tones, while performing those activities, your muscle tone needs to increase to be active. And that's a kind of visual circle, a visual and a huge circle they are coming into, because if the tone increases, then the spasticity will be more prominent, and then the activities will diminish. And that's called the inactivity circle based on constraints. And this is also happening related to the upper limb. So the impact of these constraints is increasingly due to age, due to development, and due to growth. And that's why the focus on upper limb treatment in this group became very important. This is a question. I put it in a poll, but if you would use the chat to answer this question, what upper limb treatments in children with spastic cerebral palsy do you know? And give only one example per chat so that Dina, because I can't see it on this moment, can categorize all these named treatments. So if you would use just a few seconds to name them, then it would be helpful. I can use this in the presentation.
I can see the chat, so anyone, please add to our chat. What sorts of upper limb treatments for spastic cerebral palsy do you know? All right, we have Botox therapy from 2 people so far.
Yep.
Selective peripheral neurotomy.
Yep.
Physiotherapy, tendon surgery.
Yes.
I'm going to add in another one for physio as well.
Yeah.
I'm going to add constraint therapy. Phenol blocks, occupational therapy, orthopedic surgery.
Yep.
Maybe some more specific therapeutic from our therapists who've joined us this evening.
Yeah, maybe. If I see it correctly, there are some 11 answers. So we are with 27. So if you please give an answer, it doesn't matter, but it's more that I know what are you familiar with.
Weight-bearing activities, another one.
Yep. Okay. So based on the time, we have some answers. In my next slide, I will show you the most frequently redressed therapeutic possibilities by therapists. So it's not only you, but it's from other countries. So it's more in summary. And these types of treatments are most frequently named: BOBA therapy or neurodevelopmental treatment, the constraint therapy already named, constraint-induced movement therapy, but also the bimanual intensive movement therapy, also called the habit, the botulinum toxin, you named it already, surgery, not only, so both bone surgery as tendon surgery or multi-level surgery, also at the upper limb. A lot of people name the splints or the casting, but also, especially for the very young kids, the home-based training has been named for upper limb treatment. And the last one frequently named, and that could be the same as weight bearing, related to the strength training. You also named PT or OT, and both for the BOBAT, the SIMT, the BIMT, the both PT and OT are involved in these areas. And a very special one, the phenol, the block therapy. If I put this in the line of botulinum toxin, it has a different level of effects, but has the same tendency to use. So, and now, hopefully you have the same curiosity within these therapies, what has been shown to be effective. And a helpful instrument was already presented the first time in 2013 by Iona Novik et al. Within cerebral palsy, and they developed a meta-analysis method, and they said all what was at the end was published in green had the advice do it. Orange from probably do it till unknown, and underneath the dotted line the advice for the guidelines would be probably don't do it or don't do it at all. And if you look at that part, then you see within the level of spasticity treatment or the range of motion measurement or improving on muscle strength, so that's the body function of the ICF. A positive effect, yes, botulinum toxin on spasticity for the upper limb and also lower limb. You see that the casting or using splints in the upper limb has shown some positive effects, so probably do it, but it's not very huge the effect. How bigger the circle, how more significant the effects are, and how the number of studies done are high. If you look at the hand surgeries or the upper limb surgery, there's not a lot of evidence. It's unknown in this group. If you look at the strength training in 2030, it is just in between probably do it and unknown in cerebral palsy. So within the green line, it would be especially botulinum toxin related to, okay, that would be interesting. If you look at the level of activity and participation in the direction of self-care, then you see more green lines, and then you see the constraint-induced movement therapy was very popular and has shown a lot of interesting effects. That's been advised positively. Goal-directed training, two-handed training by manual training. That's not BIMD, but it is two-handed training. Context-focused therapy. That's related to the goal-directed training, but also the OT post-botulinum toxin. So at motor activity, you don't see botulinum toxin back. And the home programs, they are all related to the infant treatment. And the same for the participation domains. The goal-directed trainings and the home trainings are named as very effective. But using our orthotics, so the splints and the casting and that level, didn't show a lot of effects, so it's still almost unknown. And if you look under the dotted line related to treatment, so both neurodevelopmental treatment and BOBA treatment, Avoita, sensory integration didn't show effect at this level. This was repeated in 2020, so they updated the level, and what you see at the innovative part is not on body function, but on motor outcome, behavioral outcome, and the functioning of the patient. And what was very good to see, that the same programs kept showing the evidence, so evidence was added, but in other target groups like DCD, developmental coordination disorder, and kids with developmental problems, again, the co-op therapy has shown to be effective. However, and at the end, for the functioning and more on the participation and self-management, the family-centered care became NCP more popular. But the co-op therapy, the cognitive approach, is not yet shown to be very effective within cerebral palsy, so it is still probably do it. Summarizing the evidence in this area, in the guidelines referring to this evidence, they say and advise all the same. They say it should be a functional approach. And the studies showing these one are goal-directed, context-specific, so home-based is for infants context-specific, activity-based, so all the programs in the green areas were activity-based, and activity-based was motor learning-based. And there is a plea for intensive approaches like constraint-induced movement therapy or bimanual intensive movement therapy. So leading to this functional approach, then if you look at all the treatment possibilities, a lot will have not been shown to be very effective. And if you look in this area at the end, we only can talk about these approaches and botulinum toxin plus occupational therapy at the level of motor outcome and participation. So why are these shown to be effective, and what should we do with this as therapists and researchers or parents or doctors? So I will show you now studies that really focus on this topic. Liane Saksowski in 2013 had performed a meta-analysis about the efficacy of all types of upper limb therapies. And what she showed with her group is that intensive activity-based goal-directed interventions like constraint-induced movement therapy or bimanual training are more effective than regular care. However, there is little evidence. If you look at dose, is the high dose compared to a lower dose in a block period sufficient to retain and to keep up the level of the sustained changes? That's up to the level of 1 year after treatment. But there's strong evidence that treatments like goal-directed home-based training are very effective and adding to the hands-on direct therapies. So at that time, still unsecure what direction we need to go at. Then we had separate groups to present effectiveness of SIMT or bimanual therapy. And in this time area, 2014, we found enough studies, also meta-analysis, that said, if you only look at SIMT, constraint-induced movement therapy, they seem to be an effective intervention to improve arm function. But that was still a little vague, but they added, okay, but if you have a dose equivalent comparison group, then they have the same type of effects. So the intensity within the SIMT matters. But if you, and SIMT is the use of the affected hand as the preferred hand, so you hamper the non-affected hand. If you compare the bimanual treatments, intensive treatments, again, Liane Saksowski performed this review at the end of 2014, then they found out that for both therapies, they had equal type of effects on motor activity related to the upper limb, but that the dose matters, and that it matters up to 90 hours or 60 hours, but if you get below 30 hours, the effects are really less, and after the follow-up effects are very low. So that is an important message. Now, ending in 2019, the last Cochrane review, and Brian Orr has performed an earlier in 2015 and updated in 2019. And then the conclusion was related to the constraint-induced movement therapies, that it will work compared to usual care, just low-dose therapy, and it is the same effect if you do a equal or high-dose therapy. Doesn't matter what other therapy it would be. So it could be home-based, it could be context-based, it could be neurodevelopment treatment, but that was not put in these studies. So the constraint-induced movement therapy in high dose can be effective compared to low dose. But the bimanual therapy, we already know, has the same level of effects. And this was studied in 2020 by Ouyang, and he showed to all types of bimanual intensive treatment approaches. And their conclusion, and it's red lighted, that they show that bimanual treatment or the habit is an effective intervention for improving motor activities within the upper limb. SIMT showed to be effective, BIM showed to be effective. If they compare, they are equally effective. So to summarize this part, you can see that at the end, at motor activity level, so the functioning of the upper limb, there are equal effects of SIMT and BIMT. The dosage needs to be far up to 30 hours, but 60 could be optimal, and studies presenting 90 hours have shown a longer follow-up effect up to 1 year. And the environment in which we perform SIMT or BIMT should be preferable home-based for the young kids, or in a specific environment. Looking at this, maybe some examples. Maybe you already know the name for a very popular treatment, especially in the western part of Europe. It's called the pirate groups. Then the kids use the fantasy game of being a pirate. You see the sling on the non-affected side. And this is the chief or the captain of the pirates, and they do a lot of games within the area of one-handed activities, individually in a group, and they try to use that motivational part to enhance the functioning of the upper limb. But also approaches of bimanual training exist for infants up to teenagers. And the first study ever was based on teenagers, and they call it recreational camp in Sweden, and they put gloves on the non-affected or less affected hand, and the kids did a recreational camp with all type of activities, and they were only hampered by a glove. And very popular became the individual occupational training within constrained induced movement therapy for younger kids, and they embedded this in schools and home-based, and all showed to be the kind of equal effectiveness. Now to look at an example of our country. I'm waiting if it's starting. Yeah, it's coming up. It's no sound in it. We perform within the constraint induced movement therapy for teenagers a 2 weeks camp in which they practice 15 days in a row, having a glove. You see they are taped so they will not put it off, and the non-affected hand is in the lead. And we do individual and group related games, sports activities in which they have the affected hand as most leading hand, the very popular baking and cooking activities for preparing the meals, and they need to cooperate, so the social effects are included, and they have a goal related to if we bake or cook, we will eat it. So we prepared our meals, and they had a short-term goal, and it was effective or sometimes non-effective. And next to that, they had also personal goals, and they spent more than 2 hours a day on the personalized goals, like doing makeup in this case, and have a specific goals related to some sports. So the kids are challenged to use the hand and to have an intensive use, so a high time on task within 2 weeks and reaching 80 to 90 hours. You see the social effect of working together in a kind of competition if it's needed. It was very successful, and we created the environment that they could work or act within this group. But also important daily activities like drinking from a cup without spoiling, and we showed them the increase. And hopefully you can see that for these kids, the fun factor was high. If you look, another example, but we change into the area of, I hope it will start, maybe need to wait somewhat longer, to the bimanual intensive treatment, because our teenagers were giving feedback on the stress using only one hand. It's not working yet. No. Come back to it. No. I will put this down again. Now it will come up. And they give us feedback on why we do these activities while we always use two hands. And they preferred the use of two hands without any glove. And we looked for activities that they really need to use two hands, like the rowing. And they were preferred activities of this group. And each year, within the 15 days, we had different activities they choose. Even the activities, and this boy is not using sticks, but normally they try to use sticks while performing a typical leisure time activity. But also, we call them outdoor survival activities that they need to be trained. And the effect of this approach is that they need to go down into a river and need to manage to get to another area. So it was directly related to effects, and the climbing is needed two-handed activities. But also getting into a boat is very challenging, and each kid has a companion, an adult companion. We call them interventionists, and they're mostly students. And we kept on a lot of challenging activities within the bimanual approach. Looking at these two approaches, knowing they have both effects, it's very wise to ask parents and kids, okay, would you go into the SIMT or the BIMT? We love to go in the bimanual area because it's really fitting into the wishes of the kids and the needs of the kids. I go ahead with the other important type of treatment was the botulinum toxin. Botulinum toxin has shown to be a lot of effect on spasticity. But in our guideline, it was mentioned that botulinum toxin would be enough to reduce the spasticity, and then I should say the hypertonia within the muscle, and it should be combined with occupational therapy post-botulinum toxin. Huge discussion was going on for years because it is paralyzing, because it is destroying the muscle entity, so destroying the muscle fibers. And yes, you make the muscles weak. To summarize, in 2020, we had the last updated review in the Cochrane about the use of botulinum toxin, and with the title as an adjunct to treatment in the management of the spasticity of the upper limb in kids with cerebral palsy. And to summarize the effects, so these are the main results that are related to the motor activities and the functioning of the kids in daily life. The combination of botulinum toxin plus occupational therapy. So therapy is more effective than occupational therapy alone. So that's not talking about SIMT or BIMT, but the care within 2-3 times a week treatment. So that's still intensive. It's not helping in quality of life or perceived self-competence. And it is, if you compare it with no treatment or placebo effects, then we also have some evidence, and we did a study on that one too, that botulinum toxin was hampering the effect. So some studies show that it will be not effective in upper limb. But the main message is it is a good adjunct for managing upper limb treatment at the level of motor function. And if you look at the needs, if you look from the functional side for the upper limb, these are typical questions, and this is an area of the upper limb for teenagers that they would like to do this type of challenging activities, but also the gaming or sports related activities, shoelaces, again, building knots related to outdoor activities, or sometimes what we call the scouting activities, but also just daily activities like using a pump or doing the games again, replacing and transferring activities. A lot of kids love to do like the contact sports, judo, in which they need to use two hands, but also to be able to dress yourself, to give a treat if you have a birthday party, and that you can share it without any help. So based on these needs, if you summarize what the best evidence for treatment is, it is intensive treatment, both constraining or by manual therapy. And if you need to consider about botulinum toxin, it is a need that you put in more intensive treatment afterward to enhance the effect of reducing the spasticity. That's my presentation. I stop sharing. So if there are questions and there's time for questioning, this was around 30 minutes. It's still open.
Thank you so much. That was, I found those camps fascinating. Just to start off the questions, you spoke about dosing of hours, 30, 60, 90. Is that per month? How do you work out the dosing?
Yeah, that's a good one, because I showed you the short period block practice, but you also have, and that's within 2 weeks nowadays. So that's, and some do it within 3 weeks, to have to reach about 70 to 90 hours of practice. For the younger kids, they use the distributed forms. So even for the toddlers and the school age kids, they use blocks of 3 times a week of 2 hours, or sometimes 2 times or 5 times a week of blocks of 1 hour and a half. And they have a period of up to 8 weeks, and both reaching up to 60 to 80 hours at the end of the treatment. So it is a typically shorter time period. If you compare, if usual care is 1 or 2 times a week, 30 minutes, then you need 6 months up to 9 months to reach that same amount. And the examples, because that's how we decided to do it, are at a very short block period. And the evidence in this area is a combination of the distributed forms and the block forms.
Thank you. Thank you very much. Just so everyone's aware, if you are interested in the handout of Prof. Ramake's talk, you can put through a request directly to SA Child on our website or on our social media sites, and we can facilitate that handout for you. He's very kindly given us permission to distribute that handout to our members that are interested. Is there any, I can take one more question if there's anyone with a pressing issue they want to have answered.
I see one question from Silla Springer.
Yes.
Do you ever use medication as diapazam as an additional treatment? To be honest, yeah, it will be especially used sometimes as a pre-start before we go into treatment by the neurologist in our country. But normally, if there's any effect shown from diapazam, it's a pump, then directly they need to consider are using botulinum toxin, and in our policy at the rehab center, we organize now bimanual intensive movement therapy. We call it camps or programs, and then the neurologist and the orthotist will first try an intensive program, and then after showing the effects and the follow-up period of 3 to 6 months, then the combination of using especially botulinum toxin, it also could be surgery in the more severe kids, that they decide, okay, then we go for the local treatment added with another program of intensive therapy. So the decision about diazepam, yeah, it will be done, but we don't in the treatment approach mostly at that time within our rehab center. In the private practices, that can be different.
Thank you very much. Zanele, I'm just going to hold your question there because that's a whole different kettle of fish. I think it's going to open a huge can of worms there. So we'll address that offline. Thank you so much, Prof. That was really lovely and really informative. And I really like the way that you do your therapy, and your camps actually look phenomenal. Thank you so much for sharing that with us.
You're welcome.
I would like to introduce our next speaker, Dr. Dirk van der Spy. Thank you so much for making the time for us today. I know it's been a tough one to get between COVID and life. It's been very tough. But so Dr. van der Spy did his undergrad and postgraduate training at Stellenbosch University. He's an orthopedic surgeon who did a fellowship in hand and peripheral nerve surgery at the Royal North Shore Hospital in Sydney, Australia. He did further training also in microsurgery and upper limb reconstructions, and has extensive experience in all manner of hand surgeries. But his fellowship training also included tetraplegic and spastic surgery of the upper limb. And I can tell you, having looked around when you had COVID, looking around for people who could possibly stand in to do this talk, that you are a unique person. There are so few of our hand surgeons who are willing to talk and practice in this field. So really a huge thank you for speaking to us today. And without further ado, you can share your screen and take the mic. You're still muted.
Okay.
Okay. Yes, I hear you now.
Okay. Hi guys. Yeah, it's Dina. Thank you so much for the opportunity to talk about this interesting topic. I think it's so true that you know, there's lots of textbooks written full about these things, but there's very little sort of, I guess, authorities that sort of can guide us in this. And my talk is really based on my training in Australia under Prof. Tonkin and Claudia Schwint, which they sort of, they have some of the classifications. And some of the things are complex, and there's no way I can do it in the given time. But especially considering the spectrum of people in the audience, I do think I will share sort of a global approach to this, especially considering the therapist and sort of the pediatric involvement and all this multifactorial in order to decisions to make surgery, to do surgery. So what I've done is I've compressed a talk with about 70, 80 slides. I'm going to focus on the elbow, the forearm, the wrist, and then the thumb. I'm not going to go too much into swannic deformities and the finger, just for the purposes of time. But thank you so much. And I must say, I've given this talk once at a South African Hands Association, and I did the talk in association with a hand therapist, because I think it is critical that you cannot do surgery in any spastic quadriplegic surgery without the help of a dedicated therapist with the physiotherapist and also the team, the caregivers are extremely important. So yeah, just a little bit of history. So Little described the mental and physical deficiencies following neonatal asphyxia. Quite interestingly, he had polio with bilateral club feet. So and he also described muscle dystrophy, and he found the Royal Orthopedic Hospital in London. So everything that we speak about, essentially about asphyxic sequelae of a neonatal event or pediatric event, was recognized by Little's. And so just generally, so my experience sort of varies from doing public work, seeing the most advanced neglected deformities with, and then also in Namibia, seeing the spectrum of state and private, people coming from the north with severe deformities, all the way through to private, where some patients have already gone through the Botox, which is fantastic, where you can have a very targeted approach into surgery. But just generally, when patients come to me, it's always nice to have the caregivers with. So before any surgical intervention is, I just find out about the general mobility status, especially upper limb, what is required for that specific limb. In terms of the mobilization, what is the support structure? There's a lot of these surgeries that you don't even going to attend if you don't have a support structure. And then for me, also association as with epilepsy is just to know if it's well managed, because there are definitely some nuances in the surgical interventions which I want to, which is important for me just to consider all the multifactorial components. And then just quickly on the exam, and this is just, and I know you guys working with this every day, but I think these are so important. Prof. Tonkin from Australia, I was always in awe to look at him, how he examined patients. It was a beautiful thing to see. But it's a different kind of examination. This is not the same examination you would do as with the typical patient sitting and you evaluating median nerve. It is touching and feeling, passive active motion, speaking to the patient, get them relaxed, and actually let the spasticity sort of goes as you work with them. So obviously general hygiene is probably one of the highest importance with regards to any deformity, and then the passive, the active range of motion, and then the combination between flaccid, dystonic, or spastic. Very important, intrinsic tightness. Volkswagen's angle is not relevant here. And then very important for me is also to consider the sensation. It is a very important thing that we don't always consider, especially with splinting, etc. Is these people generally can feel, and it is very important not to forget that they feel pain the same way as we do. So my approach for these things, very important, is targeted at getting the best possible function. It is so important for me to that is the most rewarding surgery, because the little bit changes that you do get massive improved function. Hygiene is obviously is important, and then this is the one place in where I feel that the cosmetic component does count in the background as a lower priority. But I've recently was operating some sort of 20-year-olds, 30-year-olds, where that's very conscious. Getting them out of that drop wrist posture is a life-changing, confident booster for them. So I do think, correction of the wrist in a better position might not add to so much function, but it might be a life-changing surgery for them. So just quickly, the way that I see it: elbow, forearm, wrist, digit extension, thumb extension, and then obviously we just, I'm not going to focus specifically on the finger deformities, which is a big topic and a complicated topic as well. So for me, the elbow deformity, the classification is irrelevant here, but I do think I always start with that. So that's my first intervention. With my surgery, it's usually I do a la carte, sort of proximal to distal. And the elbow flexion deformity is a very disabling one, especially as you can see in this picture. The pronated flexion deformity is a very functionless, there's very little that you can do in that position. So just my sort of tiers of, I really try to summarize this and sort of try and drop the pills, which I think, especially for you guys working also in the public, which sits with this massive load of patients. I'll try and highlight the winners here, and because we can't do all, we don't have the opportunity to operate 3 or 4 times. But just working this down, especially considering whether these patients had Botox before, I think the first Z lengthening of the biceps is great. But typically by the time I see them, Z lengthening is not enough. I'll then go to brachialis release, either sort of fractional lengthening in the muscle and then also the tendinous part. And most of these patients has elbow contractures on the volar side. So you go all the way through, work between the internervous plane, do an anterior capsule release, and then sometimes also there's very much almost like an arthrogrypotic release. I would also, like, if there's any fibers you can feel as you go and more extension, brachioradialis sometimes is also contribute to this. And the common flexor origin release, that's a massive operation, and I don't think there's too much benefit from it. And obviously then when you do that, when you release the anterior capsule, you know, that's sort of, for me, that's the deepest layer. And most of the time you can get almost full extensions. This is just for academic purposes, musculocutaneous nerve neurotomy. I just don't do it because most of these people do have some bicep function still. So so as we break it down, going from the elbow next to the, so most of these spastic conditions do have a pronation deformity. So the pronation deformity is a problem because most of the hand's function is more in supination. And when you speak to the therapist about it, there's a big emphasis. When we operate a wrist and we do open reduction internal fixations, our primary goal is to get the hand into supination. Now, this is for functional ability for this, the CP kit. This is an extremely important, but yes, disabling deformity. So basically, the Tonkin and Schwen for academical classifications is just basically, can they actively supinate beyond neutral? Can they, or there's no active supination and only you can passively get it into supination. And then the most common, most of these cases, it's got no active supination. And I just quickly want to speak about the arrows in the quiver here. And there is some guidelines with regards to correlating with the deformity or with the classification. But I just quickly want to speak about what I think works. Pronator teres release is a winning operation. So even if you just release it as part of your open procedure, it's got a long tendinous attachment on the mid-third on the radius, thin periosteum, and you know when we use it for tendon transfers, it is actually a very strong deforming force. So you have to release it from all the way from its distal third attachment all the way back. And and then obviously a pronator quadratus release, I don't think it's a very strong, powerful release. And then the pronator teres rerouting, so it's also a good option. So you just swing the vector around. I've done it once or twice, but generally in the a la carte set, a release for me is enough. And then quite an interesting transfer is an FCU to ECRB transfer. That just put the hand in a supinated position. So this is PQ release. I mean, this is what you do for distal radius. And as you know, even with the guys with fixed deformities, pronation, you're not winning that much, even if you release the capsule. So this is just a theoretical release. So you basically release PT and then you swing it around the bone and sew it back on itself. This is a difficult operation because that tendon is not as bulky as these pictures show. So it's got power, but it's I don't think it's it's a good option. And but no, our patients never present only with the pronated deformity. We've got lots of other problems as well. And then FCR to ECRB transfer is just basically, if you imagine, you know, if you take flexocarpi radialis and you swing it over to ECRB, that opens this supination deformity. Now, I think the most focus for this talk is really, and I really want to just sort of try and I'm not entirely sure how many people in this are doing actually surgery in patients, but the reality is in Africa and specific, you know, in our context, by the time people present, the wrist is the biggest deformity and that is the biggest disabling, but this is the one that we can make the biggest change. So as you know, it's a rigid flexion deformity. There's some variation with extension deformities, which I have seen. But the fingers and the wrist works as a unit. And in your surgery, and this is part of the art of cerebral palsy surgery, is to get the balance right. So Zancoli is classified basically the wrist deformity based on the ability to get the finger straight. So the group 1, finger extension. So in other words, your fingers can go straight in less than 20 degrees. So, and then the type 2 is finger extension with wrist flexion more than 20. So now you can imagine the wrist must go in more flexion so that the extrinsic can go. And then 2A is, do they have active wrist extension? And I hardly see that. By the time most people present, there's no more active wrist extension. And 2B, no active wrist extension. And then very important, the type 3, and this is what we usually see, the wrist is in flexion, and the fingers is also in flexion, and they can't get it straight even with maximum flexion. So the vector is too short. It doesn't matter what you do passively. And I so feel sorry for all the therapists that are trying to splint these things out. It is the hardest possible thing in the world to do because, the hygiene, the pressure, this is a rigid deformity. And I'll quickly just take you through the option. So consider whatever we do with the wrist, we have to balance it with the fingers. So the aim of surgery is rebalances the forces across the joint, in this case, the wrist, to allow better position for functioning. So whatever you do, you must get better finger function ultimately as well. And whatever you do, so it's so important you mustn't take away the ability. So if they can flex, actively flex, if your surgery is going to take that away, you are going to do harm. And we're supposed to do no harm. So it's very important to just maintain that flexion that we didn't do too much. So I'm going to quickly just go through the sort of sequential events. And first of all is a flexor aponeurotic release. So the flexor aponeurosis, remember FDS, FDP both have the aponeurosis, and it's a combination of a fascial and an intermuscular, almost like a slide. For those that do 10 and Achilles slides, very much the same principle, but you can win a lot with this, and this is a very good procedure. And then the flexor pronator slide, I don't want to speak too much about it. That's a massive operation where you release the whole flexor and pronator slide. If you want to do that, I would rather just do a bony wrist procedure. FCU tenotomy or a palmaris longus tenotomy, whatever is the deforming force which is not working. And then also interesting transfer is an FCU to ECRB transfer. So you take the FCU, which is a deforming force usually, and you swing it over to ECRB to get wrist extension. And then obviously the bony procedure is proximal row carpectomy with or without the wrist fusion. So how can we get better balance? So first of all, group 1, and forget about the classification here. So I'm just going to walk us through the tiers here. So this is the flexor aponeurotic release. So you can do this so you release it at the level just 6 to 8 centimeters distal to the medial epicondyle. What I typically do is I utilize the same incision for a bicep lengthening. So in other words, I would go a little bit more proximal curved linear and swing it across here, and then extend it sometimes to do the pronator teres release as well. So this is sort of the a la carte. So you can see protect the cutaneous nerve, release, cut the centimeter out of the fascia, and then go deeper and deeper. You can see very nicely the median nerve there. But in this case, all the nerves preserved, and you sequentially release the flexor, and somebody or assistant try to keep the fingers as tense as possible, and you release sequentially. Beautiful operation, and you get so much winning because ultimately you'll splint them out and that position could be held. And then, so obviously if wrist extension is present, you might consider the transfers to augment it. So in the group 2B, so these people don't have any active extension. So this is where the FCU to ECRB transfer helps. And just by the way, I'll make this also available, so don't worry too much about writing everything. So this is the only transfer for the wrist that I find that it's a good winning procedure, especially if there is active extension. So very important, this is like one of those things, and this is coming more from the first world literature, is so don't cut the FCU if you don't know the FCR is working. But by the time these patients come to us, everything is just so spastic and nothing is working. So this is really for the early cases. And I must say, typically in my practice, if these patients have still active movements and things, I would still feed them with Botox or sort of sustain the Botox for a longer time. Now, this is what we typically see in the state. You get this CP child that comes to you age 12. They come with you, sometimes they come from far and distant places. and you sit with the wrist like this. There's no splint in the world that's going to make this better. There's no tendon transfer that's going to make it better. And now we need to consider the hygiene and then move to something more radical. So soft tissue, yes, you can release the volar structures, and sometimes it's very important. And then bony and soft tissue. So the options is a fusion and obviously soft tissue. So first of all, what's your soft tissue options? Always some transfers, which I don't think at this stage it's really going to make a difference. And then obviously the proximal row carpectomy shortens the unit, and you can then do a transfer. I usually, by the time they get to this, I do a wrist, a flexor release, and pair it with the proximal row carpectomy and a wrist fusion, which is a fantastic procedure, especially those guys that's sitting in the buggies that doesn't mobilize well and needs to be dressed every day. The wrist in the neutral position is just so much easier to nurse. This is the flexor pronator slide. I'm not going to get into that. And then just quickly about the proximal row carpectomy, you can see this just opens up space. And so obviously, if you do the proximal row carpectomy, orthopedic-wise, the principle is you need to have retained cartilage in the mid-carpal and radiocarpal joint in order to do this. But by the time you get there, most of these guys, it's very hard to get them out of it. And a workhorse one-stage procedure is a wrist fusion. I find is one of the golden procedures for this. And these days, there's very nice plates available from different companies that go onto the second metacarpal or the third metacarpal, and it really makes this a really beautiful operation. So my two sort of highlights for those that's doing the surgery: the flexor apneurotic release. It's a very poorly taught procedure that I've had certainly in my training, and something we've done in Australia, and it works. It really works well with great benefit, not taking active flexion away. Flexor pronator slide, not my big surgery with little gain. FCU tenotomy transfers as needed, but the winner operation, if you've got one stage for that wrist fusion, for the for the advanced CP wrist fusion with the PRC. Lastly, I want to jump to, I know the time is almost finished, but I just want to jump quickly up to the thumb. And for those of you that's still sort of in the academic space, the House classification is based on what is the cause of the problem. So the thumb deformity is based on what the spastic component is. So obviously the most common one is the thumb, the adducted thumb. So it's adduction of the first ray, and it's adductor pollicis, and to a lesser extent the first dorsal intrinsic. And then the adduction of the first ray, and then the NCP flexion, and that's the adductor pollicis, and flexor pollicis brevis. So these are the sort of the most common one that you'll see. So that's typically the thumb that sits like this, and the web space is closed, and you've got NCP flexion. And then you get the other one where the adductor pollicis is tight, but then you've got the hyperextension of the NCP joint, which we'll quickly speak about. And obviously with the complete thumb and palm is when the FPL component is typically also involved. And I must say, if that is the case, I would have advised Botox, because that is many of these things can be treated by Botox first. So I would kindly advise, as far as possible, for the thumb deformities, try the Botox first, see which muscles needs to be involved. And then when you see what this response, if you don't win with Botox, eventually you can go on to the surgery. So the spastic, so there's three problems. The one is the spastic intrinsics. It's the weak extensors. So in other words, the extensors don't fire. And APL, EPB, EPL is not working nicely. And then we've got the additional problem with the NCP hyperlaxicity. So they go back into complete hyperextension. So basic, sort of very easy approach to this. So once we get to the resistant, the therapist has tried to spin it out. We've tried Botox, and now we've got this consistent thumb and palm. So first of all, release or lengthen the intrinsics. Matev has described the one where you release the in the palm. My view is, and I'll explain to you just now, is to actually just go and release the attachments at the thumb, and then do deep web space deepening flap. to open up the web space. And then obviously theoretically you can augment or reroute the extensors and the abductors. And then your MCP joint stability is either a fusion or stabilization, but I'll quickly tell you what I think that what I would advise for the thumb is a sort of a one-stage procedure. So obviously it's a release in palm, adductor tenotomy, flexus pollicis brevis release. Remember, they all sit the tendon attachment very close. And then a webplasty with a fascial release. So that's a beautiful procedure. I'm not sure if there's plastic surgeons in the audience, but that's I think it's very important to know to get a workhorse flap, jumping man flap, or a Z. There's a couple of beautiful ones for the first web space, which open the space, and then you can see all these intrinsics. And then theoretically EPL rerouting, or you can just shorten it. But usually these things are pretty tough by the time you get to it. And so there's some Z plasties that you can do. All principle is just to open up the first web space. And then the bony procedures, you can do a CNC arthrodesis, bad procedure, I'll never do it. MCP capsulodesis, not strong enough. MCP arthrodesis, you can do it, but you can just put a K-wire in, which give you sort of an idea of what's going to happen, and or an IP arthrodesis. So my approach to the thumb, basically, and I just want to sort of compress this topic, and specifically for you sitting in mind, sitting in front of this patient, with multiple deformities, elbow, forearm, wrist, and then the thumb. The thumb is very important because that really prevents them from having any hand function. So obviously consider what's driving the deformity. A tenotomy and a fascial release paired with the first web space deepening is a winner, for if you've got one opportunity. So in other words, you can release, you can see what is holding it back, and you can release it. And very important, this splinting is so difficult. I find I've done lots of soft tissue releases, and then the therapist is fitting a beautiful splint, and then they just wear out of the splint, and then it's so hard for therapists to splint these things out post-operatively. So my advice is stabilize that first web space, metacarpal 1 to 2 with 1 or 2 K-wires. That keeps it open, and you can sometimes leave it in there. At the same stage, if the MCP is hyperlax, you can just put a K-wire across that. Easy, quick, it's not a complicated thing. You don't have to do big bony work, but speak to your therapist, ask them, what are we going to do afterwards? But if I can give you advice, just open that web space with the K-wire. And then, if a hyperlax MCP, use a K-wire. So that in a nutshell, I'll conclude by saying, for my in the winning operations in this complicated big theme, and there are so few people do it, and there's so many of you that can do it. Consider the elbow release sequentially, flexor aponeurotic release, pronated teres release. The PR3 wrist fusion is a winner, and a basic thumb one-stage procedure gives great relief. Thanks, Dina.
Thank you so much. Really, really interesting for us who deal mainly with lower limb surgeries. A lot to learn, and I think really important not only for the surgeons among us, but for the therapists to understand that there are a lot of options out there. I think a lot of us, probably myself included, overuse Botox sometimes because we don't have the confidence to go ahead with the more advanced procedures. So certainly very, very interesting talk, and thank you very much. I know that we've gone over time. If there's anyone who has a specific question, you're welcome. Anyone that has a burning issue they need to discuss? Okay. I think we've gone a bit late, but thank you, everyone. Thank you so much, Dirk, for the talk, and to Eugene for the fantastic talks this evening. And I hope everyone goes well. And seeing as it's our last webinar for the year, I wish everyone a good Christmas, a good New Year, and it should only bring good things. Thanks.
Thanks, Tina.